morning everyone, we are group 26 and today we will be presenting a case from internal medicine. Our patient is a 45 years old female who presents with a chief complaint of joint pain and morning stiffness for the past 6 months. She describes the pain as symmetrical, primary affecting both hands and wrist. The stiffness is worst in the morning and lasts for more than 1 hour. There is associated swelling and tenderness in affected joints which improves with the activity. And she denies any history of similar episodes, no recent trauma, fever or systemic symptoms. Her past medical history has no chronic conditions or any prior hospitalizations, surgeries, medications or any allergies. She is a non-smoker, occasional drinker and there is no drug use with sedentary lifestyle which is high in processed food and low in fruits and vegetables. Family history. Father with the hypertension, mother has type 2 diabetes mellitus and there is no family history of autoimmune joint disorders.
Okay, and physical examination findings. Her vitals are normal. BP is 120 per 80 mmHg, and her heart rate is 78 beats per minute, and the respiratory rate is 16 per minute. And she is well nourished female and appears fatigue but no acute distress. Her heart rate and rhythm is regular, no murmurs, rubs or gallops, and her breath sounds are clear, no wheezes, raises or ranche, and her abdomen is soft, non-tender, no palpable mass and hepatomegaly. On the assessment plan, the extremities are symmetrical swelling and tenders in the MCP and PIP joints of both hands, and no deformity and nodules, and no edema, cyanosis or clubbing, and on skin, no rashes or lesions. She is alert and oriented, and no focal deficits.
Laboratory test, the BBC is 8000, which is normal. Hemoglobin was normal. Platelets were also normal. GSI was elevated, that is 50 mm per hour. CRP was elevated, that is 20 mg per hour. RF is positive. Anti-CCP antibodies are positive. ANA is negative. Imaging studies were done. X-ray, soft tissue swelling, space narrowing in MCP and PIP joints. MRI is synovitis in MCP and PIP joints. The differential diagnoses are as follows. First one is rheumatoid arthritis. The ruling was symmetrical joint involvement. It also had morning stiffness, positive RF, and anti-CCP bodies. Rule out is none for now. Systemic lupus erythematosus. Polyarthritis can occur in SLE, but it was rule out was negative ANA bodies. Osteoarthritis, we have ruling that is joint pain possible in involvement of PIP joint. There is Bouchard's note. Rule out was OAs typically affects the Hebridean's node, absence of osteophytes. Psoriatic arthritis can present with symmetric polyarthritis, but there was no skin finding. We also have another differential diagnosis, which was reactive arthritis. The ruling was symmetrical joint involvement, morning stiffness, positive. Out was absence of conjunctivitis, urethritis, or skin lesions, usually involves lower extremities, joints, or knees or ankles. Gout, our ruling was joint pain and inflammation. The rule out was no tophi crystal noted on imaging. Gout commonly affects the first MTP joint, or which can also be the cause for podagra. Sarcoidosis, the ruling was can present with arthritis, sometimes with Loughlin syndrome. Ruled out was lack of systemic symptoms, no respiratory findings or skin findings, no high-level lymphadenopathy or granulomatous imaging.
Final diagnosis. Symmetrical joint pain and swelling, morning stiffness for more than 1 hour, positive rheumatoid factor, anti-CCP antibodies, elevated ESR and CRP. These findings confirm rheumatoid arthritis.
Management plan. Initial treatment, we have to go with the NSAIDs for pain relief and DMARDs such as methotrexate and corticosteroids for acute flare-ups. When we use the DMARDs, there is acute flare-ups in the symptoms. And in the management plan, we have the DMARD classification, FDA approved drugs, the conventional synthetic DMARD, hydroxychloroquine, leflunomide, methotrexate, sulfasalazine, and targeted synthetic DMARD, baricitinib, tofacitinib, and upadacitinib. And biological DMARDs are classified into two types. One is anti-TNF biologics and another is non-TNF biologics. And in the anti-TNF biologics, adalimumab, ceftazidime, prazole, etanercept, and golimumab, infliximab. And when it comes to non-TNF biologics, abatacetab and rituximab, tocilizumab, sarilumab we can use. And when is the drug of choice methotrexate, we have to use 10 to 25 mg per week orally or subcutaneous, and we have to use the folic acid 1 mg per day, remaining days to reduce toxicity. And hydroxychloroquine we have to use 200 to 400 mg per day, when we have to use for less than or equal to 5 mg per kg on the basis of the weight. And when it comes to sulfasalazine, we have to use start 500 mg twice daily. And when it comes to leflunomide, 10 to 20 mg per day. Drug of choice in pregnancy women, hydroxychloroquine and sulfasalazine.
Long-term management plan. Exercise and weight management to maintain joint mobility. Smoking cessation as smoking worsens rheumatoid arthritis and reduces DMARD efficacy. Occupational therapy and assisted devices to improve daily functioning. Surgery as joint replacement for severe joint damage.
So some key learnings are rheumatoid arthritis always comes with symmetric joint pain and swelling in hand and wrist and feet. Morning stiffness that lasts for more than 1 hour and that improves with movement. Also look for progressive deformities such as swan neck and ulnar deviation. And some extra manifestations are like interstitial lung disease and pleuritis in the lungs, pericarditis and increased cardiovascular risk in heart, and scleritis in eyes, and anemia and Felty syndrome in blood. Next. Anticyclic cetylated peptide is highly specific in rheumatoid arthritis, and inflammatory markers such as ESR and CPR is always elevated, and X-ray studies show joint erosion. What are the treatments? Methotrexate is the first line treatment and should always be given as early as possible. And if it fails, we have to add biologics such as TNF inhibitors and interleukin 6 inhibitors. And for short-term symptom relief, we have to use NSAIDs and steroids. And also look out for neck instability, heart disease risk, and inflammation such as TB and hepatitis.
Stiffness and positive RF anti-CCP antibodies, which are the hallmark features of RA. The lack of DIP involvement and osteophytes on imaging rules out OA. The positive RF and anti-CCP antibodies combined with the patient's clinical presentation strongly supports the diagnosis of RA. These serological markers are highly specific for RA and help rule out other conditions in the differential diagnosis. The X-ray findings of joint space narrowing without osteophytes in the MCP and PIP joints in conjunction with the patient's clinical presentation and positive serological markers strongly support the diagnosis of RA. The patient's presentation is classic for RA, hence initial early initiation of methotrexate and low-dose corticosteroid is critical to slow disease progression and prevent irreversible joint damage. To further evaluate and confirm the diagnosis of rheumatoid arthritis, we perform HLA-DR4 testing, synovial fluid analysis, joint ultrasound or MRI, high-resolution CT of the chest, echocardiogram, bone marrow density. To approach the management of this patient, the initial treatment is methotrexate and folic acid with monitoring every 3 to 6 months. If inadequate response after 3 to 6 months, we add biologic DMARDs, TNF inhibitors, or consider JAK inhibitors. If biologics fail, we should minimize the use of steroids. These are our group members. These are our references. This is the end of our presentation. Thank you.